afternoon, everyone, and welcome again. My name is Carla Gaines. I am the co-chair of the African American Opioid Coalition of Safe Communities, and I'll be your MC today. I am pleased to welcome you to the Ending Deaths from Despair webinar series. To our knowledge, it's the only kind in the nation. So on behalf of the Dane County Executive's Ending Deaths from Despair Task Force, we thank you for joining us and for being a part of the solution. The goal of this webinar series is to save lives in Dane County, to help set a standard for communities around the nation grappling with deaths from despair, to understand what underlies these deaths from despair from the perspective of people in pain, and to provide tools to help them deal with this and to work on prevention, and to lay the groundwork for continued conversation and action on how to make Dane County's mental health, substance abuse disorder treatment systems accessible, culturally competent, and effective at eliminating deaths from despair. So I am really excited about today's presentation, and the series is entitled, You Can Do It, A Guide to Collaborative Safety Planning by Megan Anderson and Jacob Austin. Megan Anderson has her Master's of Science in Social Work and is a licensed clinical social worker. She's the clinical practice leader in behavioral health at Unity Point Health Meriter. In her current position, she provides leadership to advance professional nursing and other professional practices. The clinical practice leader is responsible for assessing, planning, implementing, and evaluating clinical programs to meet the needs and improve the outcomes of patients, patient populations, the organization, and the system. Megan is a leader of the Zero Suicide Initiative at Unity Point Meriter Hospital. Her special interests within the mental health field include working with individuals with chronic suicide issues, exploring shame, resilience, and working with caregivers and families to help them better understand their loved one and set helpful, realistic boundaries. And Megan will definitely get into all that suicidology and all of that in her presentation. Jacob Austin has a doctoral in clinical psychology with a special emphasis in primary care, behavioral health, and health psychology, as well as his master's in education. He is the primary care provider, behavioral health program coordinator at Group Health Cooperative. In his current position, he works with adolescents through older adults, focusing on clinical interests, including health psychology, chronic illness, grief, parenting, issues of aging, anger management, anxiety, and depression. Jake does it all. Jake is a low-key Midwestern psychologist trying to transform primary care. Thank you so much, Jacob. We also have Cara McAfee with us today as our moderator. She also coordinates one of our webinar series. Cara is passionate about suicide and mental health after losing her brother to suicide in 2005. She works at EPIC, where she leads the suicide prevention workshop. She's honored to be a member of the Zero Suicide Collaborative and Ending Deaths from Despair Task Force. Cara will be assisting with questions from the audience later in the presentation. So please make sure you are asking those questions, because we want to make sure that you are getting what you need. So thank you all for being here. Thank you for joining us, especially during this time of season, and especially as we just heard of our social media regarding suicide of a major artist within our nation. And so this is a perfect timing for this event today. So right now, I'm going to turn it over to Megan and Jake so we can begin this important conversation. Take it away.
Thank you, Carla, for the lovely introduction. Jake and I are here to talk a little bit about safety planning. Our main goal today is to demystify safety planning the best we can. Sometimes there's a thought that it's a little more complicated than what it actually is. And while this is a heavy issue, we really want to show you how it's done and answer questions about it. So I'm going to turn it over to Jake to talk a little bit about our plan for the next hour.
Yeah, as part of the CME process, we need to lay out our learning objectives. So this is that slide that you'll be asked about during your post-webinar survey. However, before we maybe to make those learning objectives a little real, let me just say what our real goal is here. Our goal is that you leave this webinar understanding the role that a safety plan plays in suicide prevention. We want you to know what goes into a solid safety plan. We want you to really get familiar with the specific safety plan that we think is the best. It's called the Stanley Brown Safety Plan. So we're going to kind of really explore that one. Most of all, though, we want our audience to know that this is something you can do. This isn't just for the mental health professionals with advanced trainings who have designated clinical time to do this. This is for the other people in the healthcare system who want to play a part in preventing a really devastating outcome that comes with despair, depression, a lot of other mental health conditions. We're hoping that our presentation gives you a sense that, oh yeah, this is something I can do. So I'm not really sure the scope of our audience, but I think it's worth pausing before we dive in to acknowledge that we're going to be talking about something that I'm confident I can speak for Megan when I say this. It's something we're passionate about. We really appreciate the opportunity our job gives us to work in preventing suicide. But suicide is a really heavy topic for a lot of people. I think each of us involved can say the ways in which suicide has impacted us personally as well as professionally, whether it's a family member, a friend who we've lost to suicide, or someone in our lives who struggles with suicidal ideation. We're not really sure how to help. I think it's just important to let you know that our goal is to navigate this topic professionally and also make it something that maybe feels a little bit demystified. And in doing that, we might run the risk of talking casually about something that is pretty heavy on you. Just know that our goal is to kind of hit that mark of professionalism. And if we miss it, please extend us grace. We'll do the best we can. If talking about this really causes you to feel a new wave of grief, heaviness, none of us are above the fray. Go ahead and just do what you need to do to get help from friends, family, and just seek out the care that you need to make sure that you're well and able to help others. So just the overall plan of this part of the presentation is we're going to kind of go through, what a safety plan isn't, what a safety plan is, and really kind of get into the core components of collaborative safety planning. So let's get going.
Thank you, Jake. So when we're talking about collaborative safety planning, we want to mention that this is an evidence-based practice, right? So this is something that's been studied, that's been looked at in several different populations, and was really sort of championed and developed by Dr. Stanley and Brown. Collaborative safety planning or safety planning intervention, which Jake and I will be talking about today, is really the best practice in terms of suicide prevention. So there's been lots of articles that have looked at this. There's been, lots of studies looking at this both in inpatient and outpatient care in non-clinical areas. And it really is a systematic and comprehensive approach to trying to keep people safe in the community. a lot of us who've maybe been working in this field for a while have tried other things or have heard about other things in terms of safety planning or, suicide prevention. I think I'm someone who, there's a lot of different assessment tools out there. There's a lot of different evidence-based resources. And while those are all very good in identifying, there also still has to be some kind of collaborative human interaction. That again, ideally, ideally there is a clinician and there is someone who has, mental health training who can work with someone who's suicidal. But I also think there are aspects of safety planning that can be done by anyone who cares. So that's what we really want to make sure you folks understand by the end of the day today. I also think it's helpful to note that, like I kind of mentioned, there have been some studies, right? And so I think, there was a recent study that looked at safety planning in emergency departments, and that for patients or, persons who were seen in an emergency room for suicidal ideation, if they received a safety planning intervention and then a follow-up call, which is something that a lot of hospitals in Dane County do, at least in Madison, that they were nearly half as likely to have a suicide attempt in the 6 months following. And I think the statistic is pretty telling of why we think this is so important and why we think this can save lives. Is it can honestly reduce some of the chances that someone could die by suicide by quite a bit. If someone is willing to slow down, have a conversation with them about how to keep them safe, what helps keep them on the planet, and willing to kind of help them make sure where they know where to follow up, that this is going to greatly reduce suicidal ideation.
So I think I'm starting to get a beatific glow coming in from the window behind me. If that gets to be too bad, I can pull the curtain a little bit. But just to kind of set the table for this conversation in general, we're going to use the word safety planning a lot. So let me just kind of help you understand what we mean by that. A safety plan is more than a contract. It's actually like an intervention with a patient or a person that puts together almost like a flight plan for when things get bad. Now, the cool thing about the safety plan we're going to be talking about is that it's meant to be efficient. It's meant to just take up as few as 10 minutes. It can be done quite effectively in a short amount of time. It's also very logical. So hopefully you'll take from this that it's something that is easy to remember because it's pretty organized. Also, it's more than just a plan. It is actually an intervention. Now, when we think about making a discharge plan, we think of this patient's going to go from the hospital to this nursing home. But a safety plan actually is a way of helping develop self-awareness in the person so that they can identify high-risk times and then identify appropriate strategies to feel better in those moments, building the self-awareness, the self-understanding that can have a long-lasting impact. Now, we say safety plan for short, but the word that's really critical that I would love to just underline and highlight in all of your minds is collaborative. This is not something that you do to a patient, nor is it something that a person would do while they're waiting for the nurse to come in the room. This is something where you, who are on the shore holding the rope, can reach out to the person who's in the water and help them feel grounded again, help them feel connected. It needs to be collaborative or you're doing something different. Also, it's meant to be a living document. This isn't something that when you have it done forever. People's contexts change. If you're a healthcare provider or on a healthcare team that uses Epic has actually worked with the authors, Dr. Stanley and Brown, to build this so that it can be modified over time and not just overwritten. But it's important that this is seen as something that the person kind of keeps with them, like our vaccine cards were early in the pandemic. It's something that they can turn to in times of crisis to help stay anchored. So that's kind of the general picture. Anything you want to add to that, Megan?
No, I think that was lovely. So we just want to back up just a little bit, and I always use my favorite pig with rain boots. So if you've ever seen a webinar of mine before, I probably have the picture of the pig with rain boots, because again, heavy topic, needs a little bit of compassion and cuteness to make this all palatable. But I think most of you are probably joining us live now or watching this webinar because you understand the problem of suicide and because you want to be helpful or need to be helpful. But I think it's kind of helpful just to talk a little bit about what the problem of suicide is. One of my early mentors in working in suicide prevention was Dr. Ellis. And this was at a time when I was actually kind of hesitant to engage in working with suicidal clients. I was new in the profession, and I thought it sounded really, really terrifying. I thought it sounded really hard, which both of those things can still be true for me. But what Tom said to me was, the question's not whether you're going to see a suicidal patient, Megan, it's whether you're going to know when you're seeing one. So wouldn't you rather have some of these tools and skills to actually be helpful versus kind of, burying our head in the sand? And I said, okay, yes, Tom, you are right. And so I think, again, I've been working, almost exclusively in suicide prevention, for the last 8 years. And I think it's important to sort of prepare ourselves that we know someone in our lives, professionally or personally, who's experienced suicidality. And so it's really helpful to sort of know what to do in those moments. I also think, there's a lot of myths about suicide that are out there. These might be really obvious to a lot of you, that these are myths, but I think it's probably worth sort of dispelling this a little bit as we're talking a little bit about how to combat them. So I'll turn it over to Jim.
Yeah, especially when we're talking about suicide prevention, I think some of these thoughts come up and you'll hear it in conversations as well, but there's a general notion among a lot of people that you don't want to talk about suicide with a person because if they're not thinking about it, then they might. And there's no evidence to support that. Talking about suicidal, even talking about people's homicidal ideation, there's no evidence that actually increases a person's risk of being suicidal or homicidal. In fact, there's strong reason to believe that talking about it is a critical way of preventing it. We put this one on there because it's something that I think people do with their grief. They'll say, for some, suicide is inevitable. Listen, we don't believe that. We know that it is terrible and that terrible things happen. Maybe that's what people mean, but we strive to find ways to reduce the likelihood of suicide, just like we strive to find ways to reduce the infant mortality rates in our healthcare systems. Also, this one's maybe a little more complicated, but if people make a sublethal attempt, they're not really suicidal. Maybe that's something that we could go into more in another webinar, but any suicidal gesture is an increased risk for suicide. So we see that as an important nonverbal way that we need to be making sure this person has a plan to stay safe. No suicide contracts are a helpful intervention. When I was in grad school, I was told that this was better than nothing. Get a person to commit to staying safe. That is not what a safety plan is. That's more of a cover your own tail mentality, I think, for people who don't want to maybe be sued or say that they did something. Unfortunately, what we know is that people will promise not to die by suicide. And they very likely mean that with all their heart in the moment. But when they're in their high risk moments, the pain, the hopelessness, the suffering often clouds out promises that they've made in the past. And finally, suicide attempts often take weeks and weeks to plan. I wish that were the case, but what we know is that it isn't. And having a safety plan can really catch a person at a perfect time when they're suddenly overwhelmed by the intensity of their emotional state, and they can have a reminder of something that they can do to remain buoyant for a little bit longer. So those are just some myths. I think, Megan, was there anything you wanted to contribute to that?
Yeah, I wanted to say one more thing about the no suicide contracts. We talked about that before, and I similarly, when I was in grad school, sort of learned that is a helpful intervention. And I think in addition to what Jake said, there is this reality too that if I'm asking someone to promise me that they're not going to kill themselves, it also shuts down the conversation a little bit. So as a practitioner, as a therapist, while I don't want my clients to die by suicide, I want them to talk about it. I want them to tell me what's driving them to suicide. And I think asking someone to promise to not talk about suicide just sort of can shut down the conversation and lead someone to believe that, like, oh, this isn't a place where I can talk about it. And again, talking about suicide, all the evidence and all of our own anecdotal experiences really demonstrate that reduces people's intensity around suicidality. People are talking about it because they have some ambivalence, right? If they were 100%, I need to die right now, they wouldn't probably be talking about it with you. And so because there's that willingness to talk about it, we want to build on that ambivalence. And you can't do that by just asking someone to promise not to die. Like that's not going to help build on ambivalence. Whereas engaging in a conversation, being open, and doing some safety planning really could help building that ambivalence.
Yeah, I think that's a good way of thinking about it. It makes me think of the interpersonal theory of suicide and how suicide is such a product of feeling alienated and isolated. And oftentimes talking about suicide and their thoughts makes these things that feel so unmentionable suddenly fair and safe to talk about, thereby decreasing a person's loneliness and their sense of being, a burden on others. So, I think, like you said, Megan, and like the slide points out, safety planning often just takes a person who's on their own thinking about something and balances that with suddenly there is now people who care about me or someone who's interested. And so creating greater ambivalence might be a big part of what makes this safety plan a really powerful intervention. Yeah. So
an important thing to sort of start this conversation of how do we prevent suicide, it's all of us, whatever role you're in the community, being willing to ask the question. It's not an offensive question, right? I think there was a time in my life where I was experiencing some depression. And I remember one of my cousins asked me, like, have you thought about suicide? And I was so proud of them. They're not in the mental health community. They're not in the health community. And I was not at all. And I was really proud that they were willing to sort of ask that question. And so I think that's that willingness of being willing to go there, knowing that it's not going to cause someone to be thinking about it. And so safety planning starts with our willingness to ask a question. I think safety plans are effective for anyone who has thought about suicide. Anyone who's thought about it would benefit from a safety plan. But we're not going to know if they've thought about it unless we're willing to ask. This is a picture, an example of what a safety plan looks like. This is one that a lot of the organizations around Madison use. This is based on the Stanley and Brown model. And so again, there's some references on this page, but this is what a safety plan really looks like in its physical form. But Jake and I are going to break down the components of the safety plan for everyone now, kind of step by step. But that was just a little visual aid so you could see what it looks like on paper or in my chart, for those of you whose providers have access to that in Epic.
Yeah, and I'll just add on this slide. This is very, in my opinion, patient-friendly in how it looks. It's worded in a way that doesn't jump out at you as, oh, I'm participating in a evidence-based psychological intervention to reduce suicidality. But we're going to talk about how each of these segments actually work together to be a pretty powerful, punchy intervention that saves lives.
So the first section of a safety planning, or the first step, is really looking at what we call sort of means restriction or someone's immediate risk. Dr. Ursula Whiteside, who is a great suicide researcher and suicide prevention spokesperson, really talks about means restriction as being a public safety issue. So when we talk about means restriction, what that means is we're looking at what people have access to that is highly lethal or easily accessible. And can we make any of those things that are highly lethal or very easily accessible to someone who's in crisis? Can we make those a little bit less accessible or less lethal, right? So we'll talk about what some examples of that are. reality of what Jake said earlier is that, I think sometimes our media and the movies and shows out there, they sort of, display suicide attempts as being things that people plan out. People are writing letters and making cassette tapes or whatever that might be. And the reality is that that's true for some folks. Some folks have thought about suicide for a long time. However, the actual act, or when people are in suicidal crises, it's often very acute and very, very intense and can change quickly. And so the risk of suicide can escalate really rapidly. It's difficult to predict. And so if we know ahead of time how someone is thinking about killing themselves, is there anything we as mental health providers, or we as family members, or we as community providers can do to maybe reduce the access that they have to those ways of thinking about killing themselves? So if you are a mental health provider and you're assessing someone for suicide, we should absolutely be asking how they are thinking about killing themselves. Firearms are the most commonly used method of suicide among males. I think more than 50% of people who die by suicide in the United States, and similarly in Dane County, die by gunshot wound. So if I'm working with someone who is suicidal and has a gun, I'm going to want to get that gun out of the house for a short period of time, or at least get that gun in a gun safe or with a gun lock that the person has less access to. At the end of our presentation today, we'll be sharing some resources, and there are some really great projects going on in the Dane County, Madison area, including our gun shop project, which has some local gun shops really working with the community for safe storage of firearms. I think people giving up their guns is something that is scary for folks a lot of times, and so we want to make it as less scary and as we can. And it doesn't have to be for forever, but it can be during those times of intense crisis. Similarly, poisoning or overdose is the most common method used among females. And so similarly, we do things like having a medication lockbox, or, maybe working with the pharmacy to only get 1 week of medication at a time. And again, it's not saying, sometimes the arguments to that are, well, they can just go to the store and buy more. But the thing is, when we're in a suicidal crisis, we're not always the most rational or the most, planful. I know planful isn't a real word, but my stepmom uses it, so I'm going to use it as well, planful. So we're not always the most planful folks when we are in a crisis. I know my mind doesn't work very well when I'm in a crisis. So sometimes taking away those immediate things that are most lethal can really help keep the person, give them a chance to have some intervention, give them a chance to have some rescue, give their family and friends and everyone who's watching this, a chance to do something. Here are some other things to think about. I don't want folks to go overboard. I think it's really asking your friend, your family member, your client, how they're thinking about killing themselves, and then working collaboratively, again, Jake's key word there, collaboratively, to really look at, can we reduce some of the access to it? And again, not forever, but certainly for some period of time. I've had people not drive for a while, or park their car outside of the garage if they were thinking about carbon monoxide poisoning. There's lots of different ways to be creative. But again, it starts with that willingness to ask those questions.
Yeah, Megan, if you could jump up to, I think it's slide 14 or 12, where the safety plan is modeled. You'll see that the means restriction is front and center, because it's such a crucial piece of a good safety plan. We can get into the why, we can get into the, what's caused them to feel suicidal, but frankly, making their environment safe is incredibly important to delay the suicidal act for one more day. I always think about starting it as a essay question, and if they didn't answer the essay question, give them multiple choice. So it's like, how are you thinking about killing yourself? And if they're like, oh, I don't really know. Well, have you been thinking about overdosing? Do you have access to a gun? Megan, are there other questions you like to ask to come up collaboratively with ways of filling out that first part of a safety plan?
No, I think it's exactly what Jake is saying. I like that phrase of start with an open-ended question, and then I might ask a few more questions. I might ask if they've attempted before, how they attempted in the past. I also think, if someone is like, no, I have no method planned, I have no means identified, I've not thought about that. Sometimes there's other things they can do to keep their environment safe or make their environment safe. And I think I've had people like, make sure their kitchen sink is always cleared out, or, have a different cleaning schedule or plan, or because I think there's a reality of what's causing some of the anxiety, or that's making you feel like you're a lousy person, or whatever is kind of creating that. And again, that maybe is a little bit more abstract. I think the main goal is to identify, what are the means, and is there ways that we can reduce the access to those lethal means, because that will save lives.
Yeah, increasing the friction, just making it a little harder, because there's something so comforting about having this plan that I might be able to end the suffering. But making that gun at your brother-in-law's house, or making sure your mom knows where or your mom has put the kitchen knives away, it just makes that much harder during a really vulnerable moment. This is, I think, one of the really subtle, brilliant pieces of a good safety plan. Asking a person, what are the warning signs that you're not okay? The way I usually phrase it to a person is, listen, I know 95% of the time you're okay, like you're able to push through, but those 5% times are what I'm worried about. When do you know that you're in a 5% time? When is it bad for you? So often I'll hear people say, oh, usually it's at night. Usually it's when I'm alone and I'm not wanting to call people, and I'm saying to myself, no one wants to hear from me. This is the work of therapy, building insight and self-awareness. I'll say, wow, so that's a pretty strong thought you have. Are there other thoughts or emotions that come up at that time that you can watch out for? And I'm putting into the safety plan, I just had a fight with my mom, or when I see things on social media from my friends who are really happy. Helping people identify these warning signs. These aren't just warning signs that they're feeling more suicidal, but building that awareness of instances in their life that they're more vulnerable to feeling down or desperate. Some things you might ask the person, what might someone notice in your behavior that you're not doing okay? And they're like, oh, well, when I stay in my room. Oh, okay. And how do you feel? How are you feeling when you start thinking about suicide? Helping people build insight is a critical part of facilitating behavior change. So the warning sign section really is worth dwelling on, because you can't change their response to these warning signs unless they can be aware of the warning signs. I like that Megan put on these slides the warning signs, because it's like, oh yeah, we use these all the time in life to catch our attention when we need to be more careful. So having a safety plan that helps people wake up, like, oh yeah, I'm listening to my really depressing playlist right now. Or the song, whenever my song comes on from my old boyfriend, like, it devastates me. Like, have a plan. So let's jump to the next one. Coping skills. I think, Megan, you're going to take this one away, but before you jump in, I always try to pair the warning signs with the coping skills. So if it's like, oh man, when I hear that, Milli Vanilli song, and I start getting really sad about all that high school was and my life is now, I need to go to my other playlist that actually has the songs that anchor me. So I hope I didn't steal your thunder there, but I always try to pair the warning signs with a reasonably responsive coping skills.
A great point, Jake. And I think the main takeaway from coping skills is two main points I want to focus on. One is that these are things you can do without contacting another person. I think we're going to be talking about that in a little bit of the people who are supportive, but I think it's helpful because sometimes our suicidal thoughts come at 2 a.m. when we don't maybe want to call someone, or, we don't actually want to be around people. Maybe they're not, severe enough. And so how do we learn to sort of self-regulate a little bit? So that's number one. And number two is that they're actually something you would do and that they're specific. So a lot of times when I'm looking at safety plans, I used to edit or, review, audit all the safety plans that were created at VanOrden. It's a fun part of my job. I do a little bit less of that now, but I think sometimes I would give feedback to the staff creating them with the patients if they were really non-specific. Like if it's like read, watch TV, like, well, what book are you going to read? And do you own that book? And what's your favorite book? And what book cheers you up? And what's your favorite YouTube video of little kitties, right? Like, be as really specific as you can in those moments and make sure they're actually doable. You know, a lot of us in Wisconsin, being outside is helpful, right? But if someone's coping skills are all outdoor activities, I know that most people aren't going to do all of those in the winter. So making sure they're realistic and specific is really, really helpful when thinking about safety planning.
Seasonally appropriate coping skills. I like that. So if the coping skills are things that you can do on your own, internally or even externally in your space, I think distractions, like therapeutic distractions, are the next thing. That you're still not going to the emergency department, but it's like, oh yeah, there are things, people I can connect with in social settings that can help me feel better. Megan mentioned a word that is equally important as collaborative. If this presentation has like 3 main ideas, it's like, you can do it, be collaborative, be specific. Because I think the more specific you are with each of these things, the more effective the safety plan is going to be. So step 4 is finding people in social settings that can help the person feel better. You'll ask them, who do you like to spend time with? Automatically, and Megan, I'm curious if your experience is this, but mine is like, people are like, oh, who can I ask for help? And I'm like, no. Distractions are like, who do you just want to connect with? I don't know what else to say. Just text your friend and say, hey, what's going on? Or what are you up to? Be specific though about who you're going to contact. I always encourage people to also name places they can go, realistic places. So if it's a kid who lives in Cottage Grove, it's not going to be like, oh, I'm going to go, to the Union. It's like, where's somewhere in Cottage Grove that you could walk to, or where's someplace that you can easily get to if you just ask your mom for a ride. So distractions are kind of the next level outside of the internal coping skills. And then Megan, did you want to add anything to the distractions one? Because that's one element that I've learned a lot from you.
I think you did lovely. I always call them good time friends, right?
Yeah,
so like sometimes people might not have a super robust network, which we'll talk about in a moment. But a lot of times we might have people where we can be an acquaintance, right? Yeah. Or you can go watch a movie with someone, or, go to a group somewhere, or a meetup activity, or just go to a coffee shop and sit and be around humans. Totally. So I think I use the phrase good time friends, because we all might have someone who we're not going to tell our whole life story to, but they're going to be supportive to us. Yeah.
And, I think the helpful thing that this does for the individual is depression can be so all or nothing, black and white. And it's like, I'm either going to burden my friends or I'm going to be alone. And it's like, well, are there people that you can just like hang out with? It's like, just be around like without talking about your sadness. So number 5, though, people you can ask for support. This is also kind of a mind bending thing you can do with patients. Like, are there people who love you? Are there people who you would feel comfortable saying, listen, if it gets bad, can I call you? Because if someone that you love were to say that to you, how would you respond? So on the safety plan, the Stanley Brown safety plan, we really try to get the list of the people that they can reach out to and say, listen, I'm not in a good headspace. Can we talk? Like to have 2 people, 3 people. I like to have phone numbers, even if it's in their phone, because the last thing you would want is something as stupid as not remembering a person's phone number to be a life or death issue. Because if your phone's dead and you don't have your contacts available, or for some reason you don't have your phone, you can still call them. So I think the idea of approaching people to ask if they could be a support person is a kind of a big step. And I think when you can help people take that step, suddenly the network of support that they live amidst is much stronger.
Well, one of the last things on here is professionals. So this is if they already have a primary care provider, a therapist, a psychiatrist, a case manager. We want to have all those numbers in one place, similarly to what Jake was saying. If they don't have those things, maybe that's another step of finding ways to get them connected to those resources. We have different ways of doing that here in Dane County, but I think again, kind of having those all in one place. And again, this is the idea of a safety plan. You guys saw the first picture, is it kind of goes in that order, right? We want to make sure their environment's safe. We want to be looking at warning signs, then looking at some coping skills that are internal, branching out to friends and family, then looking at who are the professionals in your life, if none of those other things are working, that you can call for help.
And I'll say just on that professional side too, sorry for interrupting, Megan. I'm often surprised at the assumptions I make about what people know and don't know. Because it's like, oh, we're going through the safety plan. When you get to this question, you say, well, who would you call for professional support? People are like, I don't know. Again, it's all or nothing. It's like, do I have to go and be admitted? It's like, well, no, there are actually steps between your friends who care for you and being psychiatrically admitted. There are numbers you can call for, real-time support. There are places you can go to be evaluated. So I always get reminded as a professional that people don't understand the systems like we do. And even reviewing with them, like, here's the number you can call if you just want to talk to someone. Here's the best emergency department to go to. Just demystifying that can be really, really helpful.
Absolutely. The last part of the safety plan is the one thing. So it's working with the person that you care about to develop or identify one thing that makes life worth living for them. I often will ask the patient, what keeps you on the planet? That's something I say, or gives you some purpose. I often want to try to allow folks to think about this or have it be an essay question, and then, again, might prompt folks. A lot of times these are external factors, like maybe it's another person, their kids, their nephews, their brother, that is making life worth living for them, or a reason to stay on the planet. The goal is that continues to develop, that the person has some hope that things will get better. So I think it's a really important step because it can be a reminder of why we're doing this.
Megan, was that on the original Stanley Brown safety plan, or is that something you all added at Meritor?
It's something we all added at Meritor, but it comes from the Stanley Brown research.
I just love that question. I think it's so powerful. It's such a powerful way of wrapping up the safety plan. I've been surprised too. And so to be able to make space to have a person say what it is that they're holding on for, really helps me feel like I know them. The best answer I've had, though, no joke, I had a patient once tell me, honestly, there are just still so many different cheeseburgers to eat. Like, what do you mean? He's like, there are things I just enjoy still, and I don't feel ready to give that up. And I was like, that's not what I thought you were going to say. I like cheeseburgers too, though.
Yeah, absolutely. So it's kind of building on that ambivalence, which we've sort of spoken to already, right? Even if there's a large part of them that feels suicidal, if there's something that's keeping them on the planet, we want to help them invest in that. We want to help them grow that to be able to continue to develop that ambivalence.
And I'll say it's also hard because so often that thing is part of their stress. They're feeling like they're a burden on the family that they would do anything for. And yet giving them space to name that and talk about that intensely adds to the ambivalence and keeps them from the act of suicide. So just to review what we've ran through in the last half hour, safety planning is something we can all do to prevent suicide. Safety planning, as opposed to no suicide contracts or other types of suicide prevention, safety plan, like using the model we discussed, is evidence-based, and it's structured. It goes from, like Megan just reviewed, first asking if the person is having suicidal thoughts, making sure that their environment is safe, developing the self-awareness so that they know what to watch out for, identifying things they can do internally and externally to stay safe and feel better, people they can connect with, places they can go. It's a logical system that helps a person develop a plan for when it gets really hard. Now, it's collaborative because often we're working with people who are feeling suicidal and aren't thinking super clearly. So it's so important that you, as a person who cares and is involved in their well-being, helps them identify some of these solutions. Be specific, though. It doesn't help if it's just a general thing that you're doing just so a person can, so you can feel better at the end of the day. Be specific, and through all your work with a person, just continue to be anchored in the reality that there is hope, that suicide is something that can be prevented. And it takes more than just a mental health professional with a 60-minute hour with a patient. It's something that we can all participate in when it comes to reducing deaths by suicide in our communities.
So we're going to turn now to a little bit more of a discussion, and Jake and I are going to just talk through a few things that have come up as questions in the past. And we also open up now to questions from the audience as well.
Great. Thank you so much, Megan and Jake, for sharing your expertise and your passion with this. I do have some prepared questions, so let's go through that to dive deeper into your experiences with safety planning. Stepping back to the beginning, how do you know if you should even safety plan with someone? What are some of the signs that you might look out for?
Well, I have a bias that I think anyone who's experienced suicidal ideation can benefit from a safety plan, even if that suicidal ideation is kind of what we call passive, meaning they don't have a plan, right? They don't necessarily have an intent to act on it, but they've thought of it. I think even those individuals benefit from having some sort of conversation, this collaborative conversation, because again, it opens it up a little bit and it demystifies it and it reduces the shame around it. But I think, how do you know? It comes back to that initial point that we made, is that willingness to ask. If you see someone who's become more withdrawn, who has been more irritable, who's showing signs of depression or anxiety that's increased, being willing to ask how they're doing, and if they've thought about suicide, if they've gotten to a point where they've considered, ending their life. I think if you're willing to ask that question, then you're going to be able to know that, oh, if that's true, then a safety plan should come in handy. But I don't know what Jake thinks.
I don't think I don't have much to add in addition to what you've said. I guess everyone's context is really different, but a lot of ideal systems will have a process in which everyone is screened for depression, and anyone who's positive for depression or says they have suicidal ideation is then screened for their level of risk. So really, like, if a person has signs of depression, it's worth screening them and completing a safety plan if you're able to.
Okay, thanks. And digging in more too, say it was a family member or a friend, thinking about starting the conversation, especially if it's with someone you haven't talked to about it. And we've talked about asking the question and being open, talking about it. What's a tip that you might have? What's one thing you could do to more easily start that conversation with a friend or a family member if you were concerned about them?
That's a really hard question because it really gets to people's confidence in talking about things that are really difficult. One of my favorite quotes in the world is by Mr. Rogers. He said something about how if things are mentionable, they're manageable. And so I'd say stumble in. You don't have to be perfect, but start. It's like, you don't want to be left wondering, should I have tried to do a safety plan? So a tip I would say is just start with care. You're like, I really care about you. I really appreciate you opening up to me about this. Would you mind if we talk through kind of a game plan? So if you lead with love, I think you're going to be met with more receptivity than if you start with, I know what's best. So I always encourage people, not just in safety planning, but in other hard conversations, to lead from the heart and let people know you care, and then do what you think is best. And oftentimes safety planning is a good structured way to make sure a person stays safe.
Yeah, and I think similarly with what Jake's saying, which was eloquent and perfect as always, is that providing a little bit of normalization, right? Of, I know a lot of people have experienced suicidality. I just watched this webinar where I learned a little bit that, most humans at some point in their life think about suicide. And so providing a little bit of normalization to help sort of decrease any shame or guilt someone might be having around this can be a lovely, lovely transition. I think in terms of like what to look for, I think if you're seeing someone behaving differently, right, than they normally do, and that can really change. Maybe they're more irritable, maybe they are more depressed, maybe they are more withdrawn. less communicative, kind of canceling plans a lot last minute. I think that's a great time to lead with love, as Jake said, and sort of just let them know you care and you want to check in on them. I think when people deviate from how they're normally acting, it's a time for us to check in with our loved ones.
Yeah, I love that. Leading with love, and just the change to baseline is a good way to know if there's something potentially off. Now, what if you start the conversation and you ask and you try to safety plan with someone that you care about and they're resistant? Maybe they say when you're filling out the safety plan that they don't have anyone to talk to. What if the conversation just goes sideways? How can you kind of prepare yourself for if it doesn't go quite as you expected it? Any tips there?
Yeah, I've talked a lot about when collaborative safety plans become coercive safety plans. And so I think like it's an important sort of thing to sort of monitor, is that it doesn't have to happen in that session. It doesn't, like we don't need to push this if there is that resistance. So I think I've certainly worked with patients and persons who have said, I've already done 5 of these, they don't work, right? Like if they've been in the mental health world, been in hospitals, right? And so I'm really sensitive to that. And so instead of like saying, oh, too bad we have to do this because I gotta check this box, it's sort of like, well, what didn't work about it? What might work instead? What might be more helpful? And I think oftentimes my fear is that it might have been the way it was presented, right? It might have been a form they were handed of here, fill this out. Versus a conversation. So I would put the form away in those instances and say, just tell me a little bit about what it's going to be like for you when you go home, or what it's going to be like for you, next week. And are there things that we can do to help ease that burden or transition that you might be experiencing? So I think people should be gentle with themselves as clinicians and as concerned family members or community members, that we don't want to become coercive, because then it's no longer collaborative, and the gem of what safety planning is then gets impacted.
Yeah, I like the safety plan as like building a bridge across a canyon. It's a nice model for a bridge. And any lines you can get across will be helpful. So sometimes if the person's really resistant, just letting them know you care and saying, like, sharing with them some resources about, professional resources in the area might be a sufficient first step. Like 988 is a great national number that is available for people to get help wherever they are.
And I was just going to say, Megan, that'd be great to share some of those resources that we have. So we have these there. If you're watching the recording later, you can dig into some of these resources. That's great. Thanks, Megan. Looking to audience questions, we did have a question that came in I can share with you. Someone was curious, what's the best way to involve family or guardians or community supporters into the safety plan with someone? Any considerations for child or adolescent patients that you would like to share?
Yeah, absolutely. I will let Jake works with children a little bit more than I do, so I will let him speak to that. But I think absolutely anytime we can involve family members or friends or supports in the creation of the safety planning is a win. So obviously if the patient or the person is open to that, that is like when we're doing really great, is if it's something that is obviously team oriented. But I can let Jake answer that as well.
Yeah, I actually made me think of like the refrigerator. It's like, I like the idea of a safety plan being printed up and like actually being on a person's refrigerator, because that means you've like normalized this. You've made them feel like not ashamed. And whenever possible, the collaboration, it shouldn't just be with the individual, but also with the family members. So I'll invite parents into the room, but I try to do it through the individual's agency. Like, I really think it'll help you stay safe if we get your mom involved. Would it be okay if we invited her in? And then suddenly the collaboration is more than just the two of you, but it's the three of you.
Great. Thank you, Jake and Megan. I'll turn it over to Carla to end our webinar series today.
I am in awe. Thank you, Megan and Jack. I just have learned so much, redirecting my frame of learning, and as a nurse by profession, just reframing what I learned regarding suicide and contracts. And now what you all have taught us today has been just so helpful. And as we look at new things that science has introduced, right? So thank you so much for this amazing webinar. I want to thank our audience for joining us today, for ending deaths from despair on this amazing series. Again, I can't thank Megan and Jake enough for really just sharing their heart and their soul and their knowledge about this important resource, for boiling the safety plan down into a manageable tool we can all use. So I'm going to definitely be looking at that safety plan personally and sharing it with my friends. We hope everyone tuning in today feels more comfortable regarding the safety plan with someone they care about. You truly can do it. That was the name of this series. You can do it. So we plan to continue these webinar series into 2023. We hope you will attend a future webinar and spread the word to others in Dane County. Thank you so much and have a great afternoon.